think intra-arterial thrombolysis is being used in a relatively prevalent use, but an inconsistent use without a clear sense of indications and a clear sense of risk and benefit. So that's why I think this is very important that this practice be evaluated in randomized clinical trials, because it's happening. I think most interventionists are using intra-arterial thrombolysis. We just don't know, and probably there is a benefit. We just don't know which patients. So I think that is why it's important that this question be addressed. That's actually a interesting and a big question. I think that on one hand, this whole question about whether there is a use for intravenous thrombolysis or not, given some of the recent combined data analysis of all the randomized trials that actually looked at mechanical thrombectomy alone versus intravenous thrombolysis followed by mechanical thrombectomy. And most of the trials have shown equivalent results because the burden of recanalization really relies on in the mechanical thrombectomy component. But there is some evidence that perhaps patients who get intravenous thrombolysis may have a higher rate of recanalization and may have a slightly better rate of functional independence. So while I think that the results are somewhat almost equivalent, but there is still some ambiguity left that maybe we can't abandon the practice of intravenous thrombolysis. Now, what would it take to actually make a major shift and say, well, we don't need any intravenous thrombolysis? The question is that a large randomized clinical trial would have to be done, much larger than the ones that have been done. Question is whether that trial is even feasible. And in the United States, we feel a particular unique challenge, and perhaps in other countries where there's a lot of patients being evaluated at one hospital and being transferred to another hospital for mechanical thrombectomy. So the decision for intravenous thrombolysis has already been made at the outside hospital. So even if you have this comprehensive stroke centers who believe that maybe there is no use for intravenous thrombolysis, and patients that come to our emergency department, we will not use intravenous thrombolysis, we'll go straight to mechanical thrombectomy. The 25 to 30% patients that have been transferred in, that decision has already been made, and the intravenous thrombolysis has already been started before the patient has been transferred. So the practicality, even at a trial level in the United States, and maybe when it comes down to actual practice, that is something that needs to be seen. Now, the question whether you could actually give intra-arterial thrombolysis as a replacement for intravenous thrombolysis, I think in theory the results are the same. I think that if you look at experimental data, that the recanalization with intravenous thrombolysis and intra-arterial thrombolysis are almost equivalent. The problem is the time it takes to get to that point. So you can start intravenous thrombolysis right in the ED. You're looking at time to start at 45 minutes, 1 hour, but to actually get to a stage where you have a microcatheter in the artery that you want to give intra-arterial thrombolysis, that time is at least twice as much. So there's a time disadvantage that actually prevents the replacement of intra-arterial thrombolysis or intravenous thrombolysis with intra-arterial thrombolysis.